Okay, I think all of our panelists are here and guests are starting to show up. So we're expecting about 50 people today. So I would assume that people will be trickling as they come, but I want to respect everyone's time. So I think we will go ahead and get started. So first I want to say hello, welcome. Thanks so much for joining us today. I'm Jennifer Crouch, Director of Development at VillageReach. And on behalf of all of us, I want to thank you for joining us for our final update on our COVID 411 initiative. Before we get started, I want to just recognize our COVID 411 donors. We appreciate your support so much, particularly Focusing Philanthropy, which really helped us create this initiative and matched all of the gifts to this campaign one-to-one. We're also really excited to announce that right now we're finalizing conversations with Gavi, the Vaccine Alliance, to match all of those gifts again. So we're expecting that by the early fall, we'll be able to move forward with more of this work and match your dollars 2-to-1. So that's a really exciting announcement for us. Okay, let's get started. I am very pleased to introduce three of my colleagues who will be speaking about this initiative. Upile Kachila, who is our senior manager for digital solutions on our Malawi team. Timoteo Chaluka, who is Visibility and Analytic Network Advisor on our Mozambique team, and Carla Toko, who is the Manager for Advocacy and Communications on our DRC team. We're going to be speaking to you for about 25-30 minutes, and then we'll have plenty of time for Q&A. You can please put your questions in the chat. If they're simple, we'll try to answer them as we go. If they're more complicated, we will answer them in the Q&A at the end of the presentation. So, Upile, over to you.
Thank you very much, Jen. So, as I think most of you know, VillageReach's mission is to transform healthcare delivery to reach everyone. In the last year, our work has increased access to quality healthcare for 46 million people. And for more than 20 years, we have been working with governments to create solutions that improve health systems and healthcare delivery. So COVID 411 was launched at the very beginning of COVID-19 pandemic to use digital solutions to help disseminate accurate, timely health information about the pandemic and reduce transmission in DRC, Malawi, as well as Mozambique. And at the time, the top priority was making sure that people know about the virus and how to protect themselves from exposure. So our goal at that time was to use digital solutions to disseminate information about COVID-19 to protect individuals as well as health workers, but also to collect data so we could understand the needs of individuals and health workers and adapt our approach and provide the governments with better data and visualization about COVID-19 so that they could make quick and smart responses. And to be clear, even though vaccines are currently available throughout countries like United States, consistent vaccine availability continues to be a challenge in sub-Saharan Africa. So even as VillageReach is working with ministries of health to plan COVID-19 vaccination campaigns, the work of COVID 411 continues to be extremely important. And though we are reporting on the completion of this campaign, we're continuing the work. And today we'll be exploring challenges in a few minutes. But first of all, I want to highlight some successes. From March 2020 through June 2021, COVID 411 digital solutions responded to over 2.2 million health questions. And more than half of these calls, around 1,300,000, were about COVID-19 alone. We also provided 15,194 health workers with information about COVID-19. And all the work that we did lives beyond the life of the initiative itself. As you can see, we have enhanced 2 national health communication platforms in Malawi and Mozambique. We also brought the COVID-19 WhatsApp-based health chat tool to DRC. We developed 3 national databases of health worker phone numbers. and we created dashboards that give the government real-time visibility. And the last time we brought an update to you, we did some deep case studies by countries. But today, as we wrap up with the final project, we'll have a broader look across the successes and challenges of the initiative as a whole. VillageReach is dedicated to transparency and sharing our experiences. So we're going to tell you what has worked for us, what did not work, what we have learned from the process, and what we intend to do next. I'll now hand over to Timoteo.
You're on mute, Timoteo.
Okay, I'm sorry.
Great.
So thank you, Billy. Thank you, Billy, for this great information. So, well, as you heard Billy say, one of our goals of COVID-411 was to use digital solutions tools to disseminate accurate information about COVID-19, so individuals will know how to protect themselves. Well, for this first goal, we used an existing digital solution called Health Center by Phone. Health Center by Phone provides up-to-date, accurate health information to callers through a variety of channels and multiple languages. So our goal is to give callers choice about how they can, access to information to help make informed health decisions. Based on the needs of the country, Health Center by Phone can include any or all of the components like hotline operators, interactive voice recording, or even WhatsApp message powered by artificial intelligence. VillageReach has already designed and scaled up Health Center by Phone nationwide in Malawi, where it's known as Chipatala Chapafoni. In 2020, just the pandemic began, VillageReach has officially transitioned this solution to the Ministry of Health. But as VillageReach, we still have plans for this solution. In this sense, we believe it that Health Center by Phone could be an amazing tool to provide information about COVID-19. We also believe it that Health Center by Phone will be important for general health information because the pandemic was already starting to limit people access to the routine healthcare. We also could replicate the solution in other countries so we could protect more people in more communities. Well, in terms of our goal, we intended to reach over 1.7 million interactions with callers in health information. Unfortunately, we were able to reach these goals as we're going to see in the next slide. So by the end of the project period, we had over 2.2 million interactions with people, mostly in Malawi, and we had over 1.3 million interactions specifically, about COVID-19. In terms of our scope, in the 3 countries that we were implementing the solution, we used digital tools to disseminate accurate information about COVID-19. While in Malawi and Mozambique, we count with the existing hotline. In DRC, we used the health alert based on WhatsApp application. So in order to operate the solution in the 3 countries, we counted as well with operators, with Malawi having the large number, as we can see in the slide. We were able to reach nationwide in terms of geographic coverage, disseminating COVID-19 topics for the 3 countries. In Malawi and Mozambique, we included, maternal and child health topics and general health topics only for Mozambique. Well, in terms of accomplishment, in DRC, we launched a national WhatsApp health on COVID, and we designed the COVID-19 models in 5 local languages. We have upgraded the Mozambique National Health Hotline with content, technology, hardware, and quality assurance procedures. We also And we also supported the Mozambique to design COVID-19 modules in several language. And we also hired, the supervisor to support updating process of the contents of other health topics beyond COVID-19. In Malawi, we also increased the existing workforce to 75 operators, and we also designed COVID modules, adding the sexual and reproductive health module during the COVID-19. Well, as you may remember that we said that one of our goals for COVID-411 was data visualization. So we wanted the government to be able to access information for a smart and fast decision making. Here is an example of one of our dashboards. We have created a similar dashboards for WhatsApp in DRC, and we are working on a dashboard for Alo Vida hotline in Mozambique. By analyzing the data, we were able to understand who is calling, their geographic location, and why they are calling for. COVID-19 questions have consistently been about 50% of the total calls. And we can see from our dashboards that 70% of the calls are being resolved when callers speak to a hotline operator, meaning that the caller doesn't need to leave home to get access to primary health care services. We also collected the questions we are receiving, which has helped the Minister of Health to make decisions about the content for public information campaigns and priorities such as the callback service. Well, you have seen in the data that the major number of our actual call volume was in Malawi. Use of the health center by phone in Malawi, we experienced a triple-digit increase in use during the pandemic period, which is a significant compared to other countries. So there is several reasons for this growth, in particular in Malawi. Malawi already had an established and efficient health center by phone. People already knew about it and knew it was reliable. DRC had no system in place, and Mozambique has a limited, inefficient hotline that when people call it most of the time, they rarely get the information they wanted. So in Malawi, we were able to ramp up almost immediately, whereas in DRC and Mozambique, we spent a lot of time developing the infrastructure. Because the government has taken over management of CCPF just before the pandemic in Malawi, they had ownership and agency. In fact, President of Malawi had declared the hotline has the official resource for all COVID-19 information. And the call code of this hotline was on posters all over the country that supported in this way the advertisements of this hotline. Well, clearly, even though we were successfully, we experienced a lot of challenges. We didn't expect the surge number, the surge that we saw in Malawi, and we expected a high volumes of calls in Mozambique and DRC. Well, first, registration and technology adaptations were challenging in both DRC and Mozambique. For instance, in DRC, it took several months to get approval from Facebook to use the WhatsApp tool. While in Mozambique, we worked, for 7 months trying to get mobile networkers operators to allow, free calls using the platform we had designed in Malawi. Eventually, we had to pivot, and migrate to a different technology in Mozambique that the mobile networks operators were open to. Secondly, this requires a tremendous amount of coordination. Even though it was straightforward, it still took time to work with the Minister of Health to align COVID-19 information with the national, messaging campaign. We needed to address each country, national priorities and translate all the information into French, Portuguese, and multiple local languages. Finally, because there was such, a need for a surge capacity, We had to work, with the Minister of Health to expand health human resources. In Malawi, for instance, the workforce has expanded from 20 to 75 hotline operators. Well, the biggest factor in our success was government buy-in. When something is a high priority for government, it's much easier to implement. We have also worked with the Minister of Health in all the 3 countries for many years, and there is a shared level of trust. We had a lot of trust with the solution providers such as Viviamo and the PrEC Health as well. Well, finally, we have demonstrated a lot of know-how. We had already talked to the Minister of Health in the 3 countries about designing or even improving the national health hotlines. So there was a confidence that we could accomplish it, what we said. Well, so what we have learned, as we saw in the volume of calls in Malawi in particular, where health center by phone already existed, countries ideally need an established infrastructure before an emergency. Eventually, for the next health challenge, probably all the 3 countries will be much better prepared. Well, national buy-in and partnerships are critical because this work takes a lot of cooperation and patience. It takes commitment for all the parties, specifically, the government side. Well, everyone is looking for information and reliable source of truth. Individuals need to know that there is a health information resource that they can trust. And on the other side, decision makers, they need to know what they have, that they have a reliable data that they can help them to make smart decisions for their country. Well, finally, one of the lessons of health center by phone in general is that multiple modalities necessary. Hotline operators can only handle a small volume of calls, and to process a high volume of calls, the ideal setup integrates interactive voice messaging as well as the artificial intelligence powered by chatbots used by WhatsApp applications. Thank you, and over to you, Carla.
Yes, thank you, Timoteo. So the second solution for COVID-411 is remote learning for health workers. This is a mobile-based solution that uses voice-recorded messages to disseminate information about COVID-19 to health workers. The reason for this solution is that health workers are at the front line of primary healthcare, particularly in rural communities. They vaccinate, treat infections, monitor health, and share health information. So we believe that if we empower them with information about COVID-19, we could more quickly disseminate accurate information about how the virus spreads, how to protect the community, and make sure health workers themselves knew how to make sure that health workers knew how to protect themselves. And contrary to previous outbreaks or epidemics, that allows for in-person training with COVID-19 restrictions, they needed a solution that would allow for distance learning. So our goals were to reach 32,000 health workers across 3 countries. So first, we had to design content. VillageReach worked with the Ministry of Health and Viamo, a social enterprise technology company, to design course materials and evaluation tools. Together, we created a series of voice message recordings about COVID-19. And the lessons covered topics such as COVID-19 symptoms, precautions to mitigate risk, and when to seek testing. So to indicate their understanding of the material covered, recipients use their phone touchpads to answer questions about the content after each module. However, It's important to understand that this had never been done before in any of the three countries. There had never been a push of information to health workers, and there was no national database of contact lists for health workers. So we were also collecting phone numbers to create phone databases in each country. In addition to the Ministry of Health, we had to go to other government agencies, community leaders, and other NGOs that work with health workers and community health workers. So this was a huge effort. And many of the phone numbers we collected were unfortunately wrong numbers or out of service. Then we had to design and implement a solution and start sending out calls to health workers. In all three countries, we had a phased approach, and we also conducted midpoint evaluations, which allowed us to shift some of our activities. Because we were running the same program in three countries, we were able to learn as we went and share lessons. And finally, we designed dashboards that provide visibility, including data points such as number of health workers we tried to reach, the number who answered the phone, completed each lesson, and their performances on the quizzes. So to highlight successes and challenges in the implementation of this solution, amongst our successes, we count strong government buy-in and interest in all three countries. The fact that Viamo, our partner, already had the messaging platform. There were no literacy required, and the lessons were available in multiple languages. The learning could also reach any type of phone, and the platform incorporated quiz questions so we could ascertain whether people were learning. And some of the challenges were the fact that when we did the midpoint evaluations, we learned that people weren't calling back when they got cut off because of the cost. So we negotiated with mobile network operators for zero cost return calls. And since our pickup rates were low in all three countries, we conducted mop-up rounds where we called the numbers that hadn't picked up. We also tried to address completion rates by changing the times of day when we called and tried out incentives in Malawi in the form of airtime, which was pretty successful. And as mentioned, coordinating phone numbers was a huge challenge. And one piece of feedback we got from the evaluations that we weren't able to address was that the speakers in the voice recording spoke too quickly. So listeners could follow them. So that's something that we would recommend changing in the future. So of the approximately 26,000 phone numbers we sent it to, about 15,000 participated in at least one module. So the next slide shows more details about the outreach. We distinguish between those who picked up a module, those who listened to a lesson, and those who answered the quiz correctly, as well as those who completed the module. So the scope of solution differs for each country. DRC and Mozambique both had higher numbers because they reached out to community health workers and health workers, but in Malawi, the Ministry of Health prioritized facility-based health workers only. We created 5 COVID-19 modules for each for health workers in DRC, 4 in Mozambique, and 12 in Malawi. And the reason for the high number in Malawi is that the government wanted this to be an official training program for the staff. We only used incentives in Malawi. And another factor we weren't able to capture is that when our team in DRC went out to observe what was happening with remote learning, we saw that groups of health workers were listening to the training together. So we think that we actually got much higher numbers of participants, but that we can't fully quantify. So other important highlights are that in DRC, we tripled our footprint from 5 provinces to 15 at the request of the Ministry of Health. In Mozambique, we expanded the cadre to include community leaders and teachers. And in Malawi, we developed a training certificate program with incentives. So the 4 key takeaways from the implementation of these solutions, are that first, there's a need to create a health worker database to pursue similar digital solutions. Second, incentives can work to increase participation. Third, early engagement with the Ministry of Health helps improve coordination and communication with end users. And lastly, incorporating end user input is important to improve the solution. So there's still a lot of interest in this solution, and with the infrastructure established, there's lots of applicability to other health topics and updates. This can be a channel to gather info quickly about outbreaks and to share information too. And now I'll turn it over to Yupile for the next steps.
Thank you very much, Timoteo and Carla. So one of the goals of our pandemic response was for 75% of our activities to have life beyond the pandemic. And now as we look onwards, there is tremendous potential to grow these 2 solutions with new health topics, expand in new geographies, and also enhance the solution's technical capabilities. For remote learning, for instance, we want to add new additional modules and integrate this into government training programs. For example, in Malawi, the government is interested in making this a component of their curriculum and also as part of the continuous professional development. We also have a lot of room to grow the health center by phone. At the moment, we're still adding content on the COVID-19 vaccine in all the 3 countries. We're finishing the upgrade on the Alovida platform in Mozambique, and we're working towards integrating WhatsApp into the Malawi and Mozambique health hotlines. We also see opportunities to use the platform to offer real-time visibility into vaccine acceptance and demand trends. So if used as a social listening platform, this is where we see the most impact being drawn upon. And to highlight some of this potential, I wanted to share what we're doing for CCPF now in Malawi. Plans are in the pipeline to use it as a social listening platform for regular and timely data collection and analysis on behavior, social, as well as structural drivers of vaccination uptake in order to inform evidence-based planning. The hotline also offers the opportunity to provide insights into what could identify as possible negative effects on service disruptions, system shocks, as well as vaccine-related events. For example, when we look beyond this particular use on CCPF, we do see the potential on using it to track adverse events following immunization by asking tracking questions and asking for information about the symptoms that clients could be experiencing at the time. So this kind of understanding can further help the government drive decisions about COVID vaccine messaging as well as response efforts. And looking beyond this initiative, it is very certain that there are so many potentials within the digital health space that are untapped and that could further strengthen governments as well as health systems, but also build the capacity of health workers and ultimately empower communities with accurate health information at their fingertips. I'll now pause here and hand it over to Jen.
Thanks, Upile, and Timoteo and Carla. That was great. I'm actually kind of surprised that I don't see any questions in the chat. Please feel free to send them. And in the meantime, I'm going to ask my colleagues some questions that I have for them. So, you know, if you guys want to come on the video, you can. I know some people are having some bandwidth challenges right now, but I'll start with you, Upile. So you've been involved with Health Center by Phone as CCPF for a long time. You helped scale it up in Malawi. You were embedded at the Malawi Ministry of Health, working with their team to help with the transition to government. So you really have been a leader in implementing this solution, and certainly in implementing it in Malawi during COVID 411. So I'm wondering about a couple of things that you saw that were new that we referenced during this presentation. So the callback service was new. The module that was around sexual and reproductive health during COVID was new. I wonder if you could talk a little bit about how you used feedback, basically feedback loops, in collecting information from callers in order to inform decisions about making those new changes to CCPF in Malawi.
Great. Thanks so much, Jane, for that question. So yes, as one essential piece of the hotline is to document all the interactions that we're having with different community members as well as the client in order to inform, possibilities to strengthen the service so that at the end of the day, it becomes a more holistic as well as integrated solution. So it was quite amazing that from the conversations that we've had so far, we were able to pick out gaps, knowledge gaps, as well as potential interest areas that were being frequently asked or requested by the clients themselves. And this helped, the Ministry of Health begin to think more broadly how else the service portfolio for CCPF can be expanded in order to ensure that information is flowing to the people in a way that addresses the hunger that they may have. So you echoed on, the inclusion of the reproductive health module. This came about because we were having a lot of questions, especially from the youth, on aspects to do with sexual and reproductive health, and that prompted the Ministry of Health to commission a training to the healthcare workers at the hotline on youth-friendly services, as well as more modules and messaging around youth-friendly health services. So in a way, there's a two-way feedback mechanism whereby the information that is being gathered by at the hotline is being used as an essential decision-making tool within the government to better serve the population, not only through the health system, not only through the hotline itself, but the entire health system across the country.
Thank you. That was great. Frederick, I see your question, and I'm going to ask my colleagues to answer that in just a minute. And please continue to put other questions in the chat. Timoteo, I'm going to continue the questions about Health Center by Phone, since Upile did such a nice job explaining about those feedback loops. So in Mozambique, things did go a little bit slower than we were hoping that they would, but they are still in progress. So, I think that one of the things that's exciting that you shared is that the work with Alovida Health Center by Phone didn't stop at the conclusion of the funding for COVID 411. It continues. And one of the things that you talked about was the Health Alert app that we use, WhatsApp app that we used in DRC. Can you tell us a little bit about how you see that being integrated into Alovida, and what is the current status of Alovida right now?
Thank you, Jens. I won't turn on my camera because my internet is not very stable. Well, the WhatsApp feature is very, very welcome in Mozambique, in particular during this period that we are implementing the vaccination process. And the idea was to incorporate the WhatsApp feature, in this sense, the vaccine check, in the efforts that the government is taking to, make the registration of the the community and the people here before the vaccination. So due to the complexities of the implementation of the WhatsApp, in this sense, the vaccine chains check based on the experience that we learned from other countries, it will take some kind of time that won't allow us to implement it, at least during the COVID period, at least this year. But we are envisioning to as well implement the WhatsApp, just to ramp up the hotline in Mozambique, adding different other features such as the chatbot, where people who have access to WhatsApp can make different type of questions related to health topic to the Minister of Health folks. So it's something that is on process right now, and we expect to based on the funds that we receive from Gavi in particular, to start to implement the WhatsApp in Mozambique.
Yeah, I think that one of the things that you mentioned in your presentation was about, pardon me, the importance of multimodal communication, and about the fact that we cannot rely simply on a hotline if we're to be able to provide resources for the entire community, right? We need to be able to incorporate interactive voice messaging, and that's why we're also incorporating this AI-powered WhatsApp. So we do have a question. So we have a couple of questions, one that is about vaccination rates and one that is about the barriers that we experience around this. So I think we'll start with the question about that applies directly to what we're talking about right now. And Carla, I do want to ask you some questions too. So one of our guests asks, were the processes that we're describing applied mainly in rural areas or also in more populated ones? And were there barriers with regard to acceptance or participation by phone versus in person? So calling into the health center by phone or using Health Alert as opposed to going to the health facility. Does anybody want to take that? Carla Toko, do you maybe want to answer that question since you haven't had a chance to speak yet?
Yes, thank you for the question. So in terms of, if I could say, the remote learning acceptance and participation, so it is true that as you presented, based on some of the numbers we were able to collect, we saw that the participation really varied from one country to another. And there were various factors or barriers. For DRC particularly, I can say that there were some network issues in some parts of the country, whereas we would send out the calls, but due to network issues, people weren't able to receive it. And we were mostly made aware of it by colleagues who would be on the field to follow up to see if people were receiving calls. So one of the biggest barriers was network issues. And as we mentioned also in the presentation, is that once somebody missed a call, they actually had the option to call back. And unfortunately, some of them did not have enough communication credits on their phone to call back. So that's where we ended up negotiating with one of the mobile network operators here to make sure that those callbacks from the trainees or the learners would be free. But otherwise, in terms of processes, there really wasn't any difference for us, whether it was in a rural or urban area. And yes, and with Health Alert, it's since it's a WhatsApp application or WhatsApp platform, really the main barrier would be those who didn't have a smartphone, and hence WhatsApp weren't able, unfortunately, to use that.
Thanks. Upile Timoteo, did you have anything else you wanted to add to that for your countries? It's okay if you don't. Okay, so Upile, Linda has a question about what you were saying around the government using information. Have you found that bears any influence on users hesitancy to use or not use Health Center by phone. How do you think the individual users feel about that?
So in all our engagements with the users, we ensure that, number one, there is privacy and confidentiality. So to begin with, the hotline workers sign an agreement to ensure clients' privacy and confidentiality is guaranteed throughout their engagement. And when we're presenting this data to the Ministry of Health for decision making, the identities of clients, they're not disclosed. So there isn't an aspect where, information would be pinned back down to the clients that offered that information. But in the event that we would want to uncover more insights, especially maybe when we're running some impact evaluations, we usually reach out to clients who are more willing to talk back and speak about their experience, and we get that consent provided from the clients.
Excellent. That's great. And for those who want to know more about Health Center by Phone, we have a lot of data around things about our quality assurance program as well, and the way in which the hotline operators are trained. So since there's several questions about vaccination rates and vaccines available, I wonder if each of the three of you could speak, since you're each in one of our countries, if each of you could speak a little bit to current vaccination rates broadly in your country and whether or not the supply is currently meeting the demand. And I want to say as a caveat that it's not necessarily, we may not have the exact numbers off the top of our heads, nor any of the three people that are on the call this morning or evening, depending on where you are, part of our supply chain program. So I'm going to offer that caveat. But maybe Timoteo, do you want to start?
Oh, okay. Thank you, Jen. Well, just to confirm, is this about COVID, right? Since I've been working also for immunization.
Yeah, that's a really great point to bring up, actually. Most of the work we do is routine immunization. But yes. Yeah, I think this question is specifically about COVID.
Okay, so in terms of COVID, the country has been receiving, from different donations, COVID vaccines. And gradually we are, including different target groups. Right now, it's open to, but with a certain age. We started with the elders, but right now we are starting to include the general people with the age below 50 years. So in terms of coverage, what the country is doing is to set specific targets based on the amount of the vaccines that have received, just to avoid situations where we have people having, the first dose, since most of our vaccines have 2 doses to be, to a person be full immunized. What the country is doing is to, set a specific target based on the amount of vaccine that we're receiving, just to make sure that, at least the target that are receiving, a specific vaccine can accomplish the vaccination process. So we are at this stage expanding to other low levels in terms of age and targets to, access, the general people.
Great, thank you. Carla, can you tell us a little bit about this current situation around COVID vaccination and supply and demand in DRC?
Yes, so in DRC, I don't have the exact numbers as of today, but as of Friday, we had a total of about 82,000 plus who were vaccinated. So initially, we only had the AstraZeneca vaccine. But since last week, we did receive about 250,000 doses of the Moderna vaccine, and we're also expecting another 250,000 doses of Pfizer. There have been other vaccines that have been announced that we're waiting for their arrival, mainly the Johnson & Johnson vaccine as well, and I believe the Sinovac. So In terms of demand, I'll say we started out very slowly, mainly because of there were quite a few concerns about the AstraZeneca vaccine, but eventually with more influencers getting vaccinated and just spending more time to explain to people that all vaccines are safe and efficient. So we're seeing more people getting vaccinated. Unfortunately, we had a month, it was mostly the month of July, between July and early August, where we ran out of vaccines. So that put a little bit of a pause. And unfortunately, it was really at a time when we were on the third wave, and finally people really saw the importance of vaccination. So once we started vaccinating again in about mid-August. We started out slowly again, only because we received 50,000 doses, and there was a focus for those who already had their first dose of AstraZeneca. But we're now seeing again an increase as it was opened up to everyone recently. So anyone who's 18 years of age and above is eligible to receive the vaccine. Although previously there was a focus on those who were above 55 years of age, those who had comorbidities, and also health workers.
Thanks. And as you pointed out, Carla, I think that the setbacks that we experienced early in the year around concerns about AstraZeneca and about the J&J vaccine, those brief interludes really set back some of the vaccination campaigns. Is it correct that DRC has a little bit of a different situation than some other countries because of having access to different cold chain storage? As you mentioned, Pfizer and Moderna, which is not necessarily available everywhere.
Yes, so for DRC, we really drawing from our experience with the Ebola vaccine. So that allowed us to have at least some cold chain supplies that could, initially receive some doses for Moderna and Pfizer, but eventually there's also there were more funding that were received, even some that were mobilized locally in order to boost really our ultra cold chain supply.
Great, thank you. Upile, can you give us a quick update on vaccination rates and supply and demand in Malawi, and then we'll answer the last couple questions in the chat.
Right. So I think for Malawi, it's a similar situation as that of DRC, where at first we had AstraZeneca in country, and the demand was really low to the extent where the vaccine was discarded, was actually destroyed because it was nearing the expiration date. And then came the third wave, which steered lots and lots of people to scramble for the remaining vaccine. And we, ran into a drought as well, where we ran out of the vaccines in country. But when we received the second batch of AstraZeneca, and now the Johnson & Johnson is in country as well, we have seen some great uptake. People are going to vaccination sites on a daily basis, which is encouraging, and hopefully the demand will continue to grow. As of now, our vaccination rate is still very low compared to the entire population. We're about, I think, 2.4% who are fully vaccinated. So they still need for a lot more and aggressive demand creation exercises that need to be deployed so that we rise up those numbers.
And continue to provide accurate information. I think we've been transitioning a lot of the health center by phone work to include COVID vaccine information too, right? So I think that's important. And really, I'm actually going to keep you on, because one of the final questions is, you mentioned the importance of support from the ministries of health with programs like this. What have you learned to be the best way to engage support from the Ministry of Health? You are there's very few people at VillageReach more well positioned to answer that question than you.
Yeah, so actually what has been very easy for us is involving the government from the onset. So from the get-go. We do not, have to begin to plan for a solution and then later on think, oh yeah, we might need some government engagement. No, that has not been our philosophy. So when we think of devising a solution, the aspect of co-creating that solution with the government comes front and center, so that whatever it is that we're devising, that solution should have a sense of ownership from the government, because once that ownership from the government is guaranteed, continuity, will also be definitely guaranteed. And for COVID, we were looking beyond the horizon. We were trying to come up with solutions that not only address COVID-19, but also should continue to grow into the health systems themselves to better respond to any other pandemics that might come. So the involvement and engagement of the government from the word go was quite critical in grounding all these solutions, but also necessitating for sustainable approaches to continue to grow those solutions beyond the current pandemic.
Great, and that helps inform our approach, right? That's part of VillageReach's philosophy, is you don't come up with a solution without integrating ministry into the conversation, because our idea is that you ultimately, hopefully, can transition a solution to be at least partly owned by government. And why would they want to take up a solution that they've had no involvement with? So I'm actually going to post in the chat for those who are on the line a link to a tool that I think, Upile, you've been involved in helping to design, which is called Journey to Scale with Government. It's an interactive PDF that we co-developed with an organization called Spring Impact. And it's all about how do you shift the mindset, both funders and NGOs and government, how do you shift your mindset together so that you are actually co-creating and working in a more positive, what we call radical collaboration. So I think that might be interesting to some of you. We have a moment for one more question if anybody else wants to know, has a burning question they want to ask. Okay, then we're going to go ahead and wrap up then. In that case, I want to thank my colleagues, Upile, Timoteo, and Carlos so much for sharing the details of your work through COVID 411. It's been my privilege to help coordinate the progress reports to all of our donors, and it's been amazing to me every single month to see how much work our teams have done in order to make this happen. And so we also want to thank our amazing donors who contributed to make COVID 411 possible, especially focusing philanthropy for matching every dollar one-to-one. It has been our great pleasure connecting with all of you for the last 18 months about COVID 411, and very glad that you were able to be with us today. And as Upile said, we fully intend to continue moving these solutions forward. We're always interested in talking to organizations and funders who want to partner with us. So please reach out. We will send you our contact information after this session, so you'll have emails for all of us that you can reach out and talk to us. Or if you just want to understand how to connect with us more generally, you can reach out to me. And then we also invite you to learn more about VillageReach's work beyond COVID 411. We dug into that a little bit here at the end, where we talked about our work on COVID-19 vaccine preparedness. And I think Timoteo astutely pointed out that a lot of what we're doing right now is continuing to deliver on routine access for healthcare for underreached communities through our supply chain solutions, through innovative solutions like Drones for Health. So thanks so much for being with us today. We're really glad that you were here. Thank you for your support, and have a great day or an evening. We look forward to the next time we're together with you. Thanks.
Thank you. Bye.